Okay, so starting with this chest radiograph, what line is abnormal here? Yeah, so this line here represents descending aorta, this line, left paraspinal line, right. So here's the azidoesophageal line, so you can see how it's deviated here. So what compartment does this correspond to? Not posterior, not. This would be the middle mediastinum. So what could give you this appearance? What could give you a mass like that in that region? So you could have an esophageal mass. Anything else? What? So a bronchogenic cyst is a classic subcarinal round lesion, right? So that certainly could do it. Anything else you might think about? So lymphadenopathy, right? So that's something else to consider. So on the chest radiograph, we can see the bulging here, and then hard to see where, but there is some, maybe a little bit of a donut there. So on CT, indeed, we do have this subcarinal lesion. So what do we think this is? So it could be what? Could be lymphadenopathy. Could it be anything else? A mass. What kind of mass? So a high attenuation bronchogenic cyst. So what's different here? All right, so here there's non-contrast and post-contrast, and now we can see that there's definite enhancement with this lesion. So is this a bronchogenic cyst? No. So in terms of your differential now, what could this be? Of what? So causing what? What would this be then? So this could be lymphadenopathy. Certainly a cause of that could be tuberculosis. There are other causes of lymphadenopathy like lymphoma. Not a good appearance for sarcoid because you don't really have symmetric hilar nodes. But what else could give you lymphadenopathy? Well, besides lymphoma, you can also have metastatic disease, right? So metastatic disease from other tumors could also give you lymphadenopathy. You mentioned an esophageal tumor. What esophageal tumor would you consider here? What?
I don't know.
Not really, because that tends to give you circumferential thickening of the esophagus. Again, those lesions, so the adenos tend to occur distally, the squamous cells a little bit more proximally, but those tend to give you obstruction, right, and circumferential thickening of the esophagus. So what kind of esophageal tumor would look like this? An enhancing mass. Most of it looks like it's outside the esophagus, right? So what kind of tumor would that be? That would be a GIST tumor, gastrointestinal stromal tumor, right? So that probably should also be your differential here. But this was lymphadenopathy from tuberculosis. So the important thing is when you have a subcarinal mass, if there's enhancement in it, then we can't call it a bronchogenic cyst, even though it's in the typical location for a bronchogenic cyst. There's another example where we have a nice subcarinal mass here on the frontal view, and on the lateral view again, some opacity there in the subcarinal region. And then this time it is low in attenuation, fluid attenuation, and this is a typical bronchogenic cyst in this particular case. Here we have another lesion out here in the lung parenchyma. So what's different between this scan and this scan? I'll tell you, one is pre and post. Okay, this is somewhat delayed. So what's different between pre and post? It's not enhancing, okay? So what could this be? So what's the attenuation of this? Fluid. So you have a fluid attenuation lesion like that. What's your differential? What could this be? What? So do bronchogenic cysts occur in the lung parenchyma? They can. About a third of them can. So the bronchogenic cyst isn't a differential. What else could this be? If this was in the fissure, what would you call it? A pseudotumor, right? You could have loculated fluid in the fissure, so that could be a pseudotumor, right? If this were in an airway, what would you call it? Mucocele or bronchocele, right? So you could have a dilated airway with a fluid collection in it, which is a mucocele or a bronchocele. Okay. Is there anything else this could be? What might give you a fluid, well circumscribed fluid collection like that in the lung parenchyma? Is there anything that could do that? Anything else? What infection might do this? No, around pneumonia, you'd expect to have more consolidation around the lesion, right? Because that's a pneumonia. But this is a well circumscribed fluid collection. What if it were in the liver? What infection gives you a well circumscribed fluid collection in the liver? Hydatid cyst. Can that occur in the lung? Yes. Yeah, so a hydatid cyst could also give you a lesion like that in the lung parenchyma, a well-circumscribed fluid collection like that. This was an intraparenchymal bronchogenic cyst, though. Okay? So bronchogenic cysts represent cystic reduplication of the tracheobronchial tree. Most are mediastinal, some can occur within the lung parenchyma. So these are usually fluid in attenuation, but if they communicate with the airway, which can occur if they get infected, sometimes you can have unusual appearances like this with an air fluid level. The subcarinal location is the most common location for a bronchogenic cyst. Other unusual appearances, sometimes you might have some calcification along the cyst wall. We can also see that with a bronchogenic cyst. This is a high attenuation bronchogenic cyst. These can be high in attenuation on non-contrast CT because they might have proteinaceous fluid. So you can have a high attenuation lesion like that, and that's why it's important to do pre and post contrast. It will not enhance after you do contrast, as in this example. On MRI, they can be higher than fluid signal on T1 because of proteinaceous contents, but they will be very bright on T2-weighted images, and there will be no enhancement, just like with CT. So on MR, there's no enhancement within these lesions for bronchogenic cysts. All right, so this patient has a vague retrocardiac opacity, so we can see it here on the CT. Anybody want to say anything about this? Any characteristics that you notice? Low density where? So the lesion itself is low in attenuation. What about the surrounding lung? What do you make of that? That's also low. So what would account for that? Air traffic. What could this be? A CCAM?
Yeah.
Any other clue? What did you mention? So what would you look for? Do you see anything that fits the bill? So there is this vessel here, right? You might wonder about that. So if we look here, what do we notice? Yeah, so there's a feeding vessel coming off the aorta going to the lesion, right? So what's your diagnosis then? What's our diagnosis? How do you, How do you know if it's intrapulmonary or extrapulmonary?
I thought it's the feeding vessel that comes off the aorta. It's more like higher likelihood of being intrapulmonary.
Both of them have systemic feeding. That's what you look for to make diagnosis of sequestration. Systemic feeding. Well, what do we see here?
Oh, a connection to the tree, tracheobronchial tree.
That's not what we're showing here. What are we showing here? Are there multiple feeding vessels? What's the feeding vessel?
The one from the aorta.
Do you see the feeding vessel? It's this guy coming off the aorta, right?
Yeah.
What about the draining vessels? Where are they going? Where are the draining vessels going?
It's the heart.
What vessels are these? Those are pulmonary veins, right? So it's draining to the pulmonary veins, right? So what kind of sequestration does that? Intrapulmonary or extrapulmonary? Intra. Yeah. Okay. So sequestration, abnormal mass of lung tissue, it's sequestered from the tracheobronchial tree. It has no normal connection to the tracheobronchial tree. The blood supply is via an anomalous systemic artery, typically off the aorta. So you can see if you see a blood supply coming to the lesion from the aorta. They can be heterogeneous in attenuation, like you see here, and they can be intralobar or extralobar. So the intralobars have no pleural covering, the extralobars have a pleural covering. Pulmonary venous drainage, usually intralobar, systemic venous drainage for extralobar. Both are more common on the left side. Congenital anomalies more common with extralobar sequestration, so you can think of this as more of a congenital anomaly, and that's why these are usually diagnosed at a younger age, and more common in males with extralobar sequestration. Infection is more common with intralobar sequestration, so it's said that the pleural covering protects the sequestration from infection. So recurrent pneumonias can be a symptom of an intralobar pulmonary sequestration. Okay? So an extralobar sequestration tends to be very well marginated because it has a pleural covering. So it's very sharply demarcated from the surrounding lung. But for any type of sequestration, you would look for the feeding vessel and arterial supply, systemic arterial supply, usually from the descending thoracic aorta. Although in some cases it can come up from the abdominal aorta, which is important to note, especially if the patient's going to go for surgery, because they're going to have to know where that vessel is coming from. So we look for usually opacity at the lung base. The extralobars have better defined borders because they're covered, they have pleural covering, whereas the intralobar may be more ill-defined. So we look for that feeding vessel from the aorta, and surrounding air trapping, the surrounding emphysematous lung, can be associated with a sequestration. Again, they can be heterogeneous in attenuation. They might have fluid areas too, but we look for that feeding vessel coming from the aorta going to the sequestration to make the diagnosis. And then surrounding air trapping or air trapping near related to the lesion, we can also see that with these sequestrations. So this is a young patient who has this kind of cavitary lesion here in the right lower lung. So the patient had recurrent hemoptysis, which required embolization to get it under control. So at the time of embolization, what vessels are feeding this lesion? Do you see where the lesion is on the angio? Well, is it going to be on the right or the left? Right. What side is the right? Be on this side. Okay. So you see all these vessels here, right? All of that stuff. That's over here. So what vessels are supplying this? Well, what are these guys? Those are intercostals, right? So you have, and also these tangled vessels coming off the intercostal arteries that are supplying this lesion. So this has a systemic arterial supply, right? So what is this lesion? So what is a pseudo-sequestration? What's the difference between a pseudo-sequestration versus a sequestration? So this is, as opposed to sequestration, which is a congenital lesion that has a well-defined arterial supply. A pseudo-sequestration is an acquired lesion, usually from chronic inflammation. So what happens is the chronic inflammation results in hypervascularity, and we get these parasitic vessels here off of the neighboring vessels. And you can see how the supply, rather than being one very well-defined vessel, you have these other smaller vessels that are supplying this. Now, these are under systemic pressure, and these are friable vessels, which is why that these patients can be at increased risk for hemoptysis. Okay? So that is called a pseudo-sequestration. So it's a form of intralobar sequestration that is acquired from neovascularization of chronically inflamed tissue, as in this example here. Okay? Usually can be bronchial arteries or intercostal arteries that supply. All right, what's abnormal in this chest radiograph? Is that a normal chest radiograph? Yeah, so what are you thinking about? Sure, so if you have a retrocardiac opacity with air, and especially if you think it might be an air fluid level, first thing to think about is a hiatal hernia, right? So you have a retrocardiac opacity with air in it. So it's your typical appearance of a hiatal hernia. Very easy diagnosis with CT. You can see the hiatal hernia there, so that's not a problem usually. And then what about this? What's abnormal here? Where's the abnormality? Do you see it on the lateral? What do we see on the lateral? Yeah, so here posteriorly you have this lump, okay? Oh, I think it's here. So what do you think that is? What gives you an appearance like that? This is a very typical appearance of a lateral chest radiograph. What could this be? Yeah, so that's the appearance of a Bacillus hernia. Okay. Again, a very easy diagnosis with CT. We can see actually the defect in the diaphragm itself, and then the fat within the abdomen comes up through the defect into the thorax. Right, so that is a Bacillus hernia. Okay. What is this? This is a Morgagni hernia. So the Bacillus hernia occurs in the back, the Morgagni hernia occurs in the cardiophrenic angles here in the front. So that's a Morgagni hernia. Okay. So these are the different types of hiatal hernia, of diaphragmatic hernias. Hiatal hernias, Bacillus, Morgagni hernia. So the hiatal hernia, you're familiar with the sliding, and the paraesophageal hernias, where the whole stomach can sometimes come up into the thorax. Then we can see the air fluid level there as the stomach comes up herniating into the chest. So air fluid level, nice sign of a hiatal hernia, very easy diagnosis with CT, usually not a mystery. The Bacillus hernias, these occur posteriorly. They tend to increase with age. What happens is that the weakening in the diaphragm gets bigger and more stuff starts to herniate, especially if the intra-abdominal pressure increases in these patients. So most patients are older. So we look for that round hump along the posterior aspect of the diaphragm. On the lateral view, it's a typical appearance. And CT, very easy diagnosis. You can see the defect in the diaphragm, and easy to see the defect in the diaphragm here, and we can see the fat coming up into the chest. And on the radiograph, it gives you a nice lump there posteriorly over the posterior costophrenic angle on the lateral view. So again, a typical appearance, very easy diagnosis for a Bacillus hernia. The Morgagni hernia, these occur anteriorly over the cardiophrenic angles, especially over the right. So look for a cardiophrenic angle mass, and we might see fat or bowel within the hernia. So this patient had these funny looking air collections over here and this represented a very large Morgellons hernia. You can see there's colon coming up into that hernia sac. Okay. So this patient has this funny looking lump over here, right? And then here's the CAT scan. So what can we say about this? What's the lump? What is it?
Is it the liver?
So how do you know it's the liver?
You can see vasculature on the top left.
Yeah, so we can see that there are vessels in here. It's the same attenuation as the liver. Also, there's a nice sign that's demonstrated here. What is this sign called? That's a collar sign. Collar sign. Something coming up through a hernia. You get this indentation where the diaphragm is, where the defect is, as whatever it is coming up through there, right? So this is liver that is herniating through a diaphragmatic defect. So what's the story? How could this occur? Well, what do you see? So these are old rib fractures, right? So this is a patient who has a remote history of trauma, had a diaphragmatic hernia here, and it comes back after the rib fractures have healed, and we can see that there's liver now herniating through this rupture in the diaphragm. That was a complication of this patient's trauma. Okay. What do we got here? Yeah, so it's one of the best common tail signs you ever see. So what's the diagnosis? Yeah, so rounded atelectasis. So what do we look for to make the diagnosis of rounded atelectasis? We look for, so you look for pleural-based opacity, 1. You mentioned the sign, the common tail sign 2, right? Another thing we look for is what? What else do we look for? Pleural abnormality, right? So usually it's pleural based, but there's a pleural abnormality here, right? So in this case, what's the underlying cause? Not asbestosis, but what? What do you call this? Asbestos-related pleural disease, right? From asbestos exposure, right? So rounded atelectasis can be associated with it's typically associated with pleural abnormalities. So what happens is anything that gives you abnormal pleura, the lung kind of folds in on itself and becomes adherent to the pleura and sticks to it and then never unfolds. So you get this rounded atelectasis that gives you this. Usually, I mean, they say that what happens is there's a pleural effusion, and then when there's a pleural effusion, the lung kind of folds on itself, gets stuck to the pleura, the effusion goes away, the lung never re-expands, and so you get this common tail sign appearance of the rounded atelectasis. The other thing you look for is, remember, it's atelectasis, you look for volume loss. So there's typically some volume loss within the lobe that's affected. So those are all the findings of rounded atelectasis. By the way, collapsed lung can enhance this really nicely, right? So you look, it's a nice sign of, atelectasis, that uniform enhancement of the lung. Okay? So we look for that opacity, pleural-based opacity, abnormal pleural thickening, the common tail sign, vessels, bronchi curling in towards the lesion. That's what gives you the common tail sign. And then there's also volume loss. So volume loss is also associated with it. There's volume loss in the lobe that's usually affected. Okay, that's rounded atelectasis. So this patient has a mass over here, and the CT looks like this. So what are we dealing with here? So this is a pseudotumor, right? So this is fluid that's loculated within the fissure. Okay, it's fluid attenuation. And so when we have fluid loculated in the fissure, it can resemble a mass, and the mass conforms to the boundaries of the fissure. So it might change in shape on your frontal and lateral views because it follows the anatomy of the fissure. Again, easy diagnosis with CT because we can see the location, relationship to the fissure, and the fluid attenuation. A very typical appearance is fluid in the minor fissure. It gives you this biconvex shape. And it can also change shape between the frontal and lateral views as it follows the contours of the fissure there. So this biconvex shape, very typical of fluid loculated in the minor fissure. And when the fluid goes away, the tumor goes away. So that is a pseudotumor. Then on CT, we can see the location, and we can see its fluid attenuation. And it's common to have fluid elsewhere also. So there's also fluid elsewhere within the pleural space when we have these pseudotumors. Okay? So what do we have here? What's abnormal in this case? Well, we have a tubular opacity that's branching. What's the attenuation of this? It's what? Low. How low? Yeah, so it looks like it's fluid attenuation. What do you notice about the lung?
Air trapping.
There's air trapping in the surrounding lung. So again, things that are tubular, we think of vessels that are tubular, but this is not enhancing, so it's not a vessel. So what will this represent then? What will this be? So mucoid impaction, right? So with these findings of a mucoid impaction with surrounding air trapping, we get to the diagnosis of how quickly we forget. So what is this? Well, allergic bronchopulmonary aspergillosis can give you mucoid impaction, right? It can be associated with air trapping, but usually when you have such pronounced air trapping around an area of mucoid impaction, we think of something else. What do we think of? Congenital bronchial atresia. So what happens is there's an atretic bronchus here, distal to it, you get the mucoid impaction, and then because of the lack of communication, you get air trapping here in the lung that is supplied by this region. So that constellation of findings, this area of mucoid impaction with pronounced surrounding air trapping, we think congenital bronchial atresia. And then so here you can see the mucoid impaction, the surrounding air trapping, very nicely demonstrated there on that image. So mucoid impaction, branching opacity, surrounding air trapping. By the way, if you're looking for air trapping, what's a nice reconstruction you can do to demonstrate it? What is this called? This is a MINIP, right? As opposed to MIPS that you do when you're looking at blood vessels, maximum intensity projection. If you're looking for air, you do a MINIP, minimum intensity projection. So it shows you the air trapping very nicely. So if you're looking for emphysema, if you're looking for air trapping, you can do MINIPs. Okay. So bronchial atresia, left upper lobe most common, then left lower lobe, then right middle lobe. So you look for the area of mucoid impaction, and you look for the surrounding air trapping. There's paucity of vessels because of hypoplasia of vessels due to the hypoxia. So branching opacity, surrounding air trapping. So the branching opacity represents mucoid impaction, and you can see the surrounding air trapping there nicely on the CT. So that's congenital bronchial atresia. All right, so this person has a big mass. Where's the mass?
Left upper
Well, I gave you a lateral view.
anterior compartment.
Yeah, so you got a big mass here in the anterior mediastinum, okay? So, of course, you see, by the way, what is this thing doing? Yeah, it's extending into the chest wall, right? So certainly we think malignancies. What kind of malignancies would you think about here? Sure, lung cancer, lymphoma, right? Something like that, metastatic disease. But I'll tell you that this is this is in this lecture, this is a benign lesion. What could this be? Is there another finding, by the way? Are there other findings on the CT? What?
Are those tree and bud opacities?
Not quite. What are these? Yeah, these are cavitary lesions. But would septic emboli explain this? From what? So what are infections that can involve the lung parenchyma and the chest wall. What are the infections that we think about that can do that? So in an immunocompetent patient, the first infection you should think about is what? In Newark, the first infection you should always think about is Newark, TB, tuberculosis, right? So that's the first thing you think of. There is another unusual infection that can affect immunocompetent patients that can extend to the chest wall. What infection is? What do we call that? It's an unusual infection. What is that? Well, nocardia, which is what this was, nocardia in an immunosuppressed patient. This was an HIV patient with nocardia. This was nocardia. But in an immunocompetent patient, what infection? Actinomycosis. Yeah, actinomycosis. So TB, actinomycosis, and in a patient who's immunosuppressed. This patient with HIV, no cardiosis. This was a case of no cardiosis. Okay. So this patient has a lesion here in the right upper lobe, looks very ugly, goes for a PET scan, and of course it was hot on the PET. The patient got biopsied 3 times because nobody could believe the diagnosis in this patient. Oh, look at that, there's the PET scan. Well, what is this supposed to be? What should this be? What should that be? Cancer, right? That should be a lung cancer, right? Is there any doubt that that's got to be a lung cancer? Gets biopsied 3 times because nobody could believe the diagnosis. The diagnosis was cryptogenic organizing pneumonia. Now, not that if you see a case like this, the first thing you're going to say is organizing pneumonia, but just to point out the fact that sometimes, you have no hope of getting the diagnosis right. Okay, and sometimes in some very fortunate patients, something like this does happen where an inflammatory lesion really can mimic a malignancy. Okay, so that is our discussion of non-neoplastic masses.